Okay, so top priority questions in surgery, guys. Now, are you paying attention? We are moving on to the depth of surgery. So, what are the top priority questions? You should know everything about gallstones. So, it's also called as cholelithiasis, right? And it will cause what? Cystitis. That is cholecystitis. It will cause. So, there can be cholesterol stones, bile pigment stones, calcium stones. Okay, and then it can cause cholecystitis, it can cause mucosal empyema, it can cause gallbladder cancer, it can cause choledocholithiasis, that is in the duct, it can cause biliary fistula, it can cause pancreatitis, very important. Pancreatitis cause can be gallstone. Okay, and then gallstone ileus, it will block the intestine. How will you treat gallstones? Medical treatment only if it is pure cholesterol, very rarely only if you refuse surgery or something, they are ready to try some dissolution treatment, okay. Surgery, otherwise everything is surgery. That's why it is a very important topic in surgery. So basically you'll have to go laparoscopically, make all these holes wherever they are telling you, and then you should know the procedure like we told you. You have to know the steps where and all you'll make the hole, etc. And then what are the complications? They will ask you, what is it called as cholecystectomy, okay. So usually they do laparoscopic. Understood, guys? They'll do laparoscopic cholecystectomy, but otherwise they can do open. When will they do open? Only if there's a perforation or there is any other complication, which can be what? If there is something called as Mirzi syndrome, okay, that is, we'll show you Mirzi syndrome. Where is it? If there is impacted gallstone, right, there is inflammation because of the obstruction, only that time they're doing an open cholecystectomy. Otherwise, they're always talking about laparoscopic. But laparoscopic also they can convert into open only if they cannot find this Callet's triangle and if it is a contracted fibrous gallbladder, etc. If there is some injury to bile duct, if there is some, if they think that partial cholecystectomy is an option. So some conditions are there when they are thinking of converting it into an open. Otherwise, they will do what? Laparoscopic. How will you do all this procedure? Where to make incision? All that you have to learn. Okay. There is something else called as Mercedes-Benz sign. Where did you go, baby? Mercedes-Benz sign. Please come back. Yeah, here. See, this Mercedes-Benz sign is a very unique name, right? Where will you find it? Means you will find it in gallstones. Okay. Which type of gallstone? You will find it in triradiate gallstone. You will find this Mercedes-Benz sign. Okay. There is also Siegel sign, which is biradiate. Okay. So you can see here, it's written here if you're getting confused. We're not focusing too much on one question, but look at this triradiate Mercedes-Benz sign, biradiate Siegel sign. Okay. All this terminologies you will write and your fancy answer is ready for you for gallstones. Now let's go to the next topic. Volvulus or sigmoid colon. So basically your sigmoid colon will twist upon itself and it will cause a problem. Usually this you can resolve by putting some gas or something and you can untwist it, right? And it has to go 1.5 round to twist. So in this you will see this coffee bean kind of thing or a omega sign. So all these names you should know, okay? That is what is very important. Bird beak they are saying when you give enema, is it? So all these specific things you should know, okay? How will you treat Hartmann procedure? See here how they have opened a stomy kind of a thing here. So this and all you should pay attention to. Hartmann procedure, where will it come? Sigmoid volvulus, okay. So specific words, if you know, that's more than enough. What are the specific words? Omega, coffee bean, bird beak, Hartmann. Yeah. Let's go to the next one. Guys, focus. You have to pass surgery means all this you should know. Mass in right iliac fossa. Right iliac fossa. First, where is right iliac fossa? Do you know? Do you know from where to where it is called that and all that? So first of all, you have to draw mid-clavicular line and then here you should draw transpyloric plane and then the intertubercular plane. Okay, the red ones, transpyloric and intertubercular. And vertically what is it? Mid-clavicular. That will give you the 9 quadrants. Okay, in the 9 quadrants, where is this right iliac fossa? Right iliac fossa is here. Are you paying attention, guys? Here, right iliac fossa. Now, if there's a mass here, what will it be? Obviously, you're seeing what organs are there here. Cecum is there, appendix is there. So, it can be appendicitis. What else can be the cause? So many things, lymph node, ileocecal tuberculosis, right? Because the ileum part is there here. All that you should write. So it can also be a mesenteric lymph node. So these are the only 4 things you'll have to write. Appendicular mass or an appendicular abscess, ileocecal tuberculosis, carcinoma, cecum, mesenteric lymph nodes, okay? Other thing, lot of things they have written here. Like a fibroid uterus, ovarian cyst, right? All that you can write. The next top priority question in surgery, renal calculi, that is kidney stones. We are doing well, guys. Focus, you're doing good. Focus here, you want to pass surgery. These are the important questions you should know. Kidney stones. Now let's come to kidney stones. So basically, in males it is common and in female infectious are more common. There will be pain here, the renal angle. Please pay attention here, the renal angle, and there can be hematuria, etc. So you should know that there is mass in the loin, tenderness in the renal angle. Okay, all this you should know. Causes of kidney stones can be because of some kind of food, okay, it can be because of food, it can be because of infection, etc. Especially in female infection, we told you. There is some Randall's plaque theory, you can look at all this. The types of renal stone, guys, you have the calcium oxalate stones, look at this, this will be usually sharp edges, so it can have hematuria associated. Uric acid stones are the only ones which you have to remember as radiolucent, okay, remember that. Radiolucent is uric acid, so it's very difficult to detect it on X-ray. Now then you have something called as a triple phosphate stone or a struvite stone, or also called as a Staghorn calculi. This will take the shape of the renal pelvis itself, right? And these are so huge, that's what you have to remember. And each of these have a crystal structure also. So the crystal structure for this will be this kind of a coffin lid, isn't it? Coffin lid kind of an appearance, okay? What else you should know? Then coming to cystine stones. Cystine calculi, these are cystine stones are actually very, they are very hard. They are very, very hard, okay? And they'll be hexagonal like this crystal structure. So remember, they are very hard. So all this you can read. We have very, very detailed videos about everything that we are telling now. Okay, so don't worry much. This is just an overview we are telling you. So all this you have to know. Xanthine stones are also there. These are red. These are also radiolucent, they are saying. Okay. Anyways, don't focus on that. Mainly they will ask you such things like what are the complications of renal stones. This they will ask you in Viva and all that, okay. So there can be hydronephrosis, pyonephrosis, renal failure can happen, carcinoma can happen, right? What are the complications we just now told you? Pyonephrosis, hydronephrosis, renal failure. What else did we tell you? Carcinoma. So are you paying attention? Okay, good. So then these are the investigations you will do in this. You will have to know some names. Okay, the names will be DMSA scan, that is dimercaptosuccinic acid scan. Then you have the DTPA scan, that's the diethylene triamine pentaacetic acid scan. Then all this you should know. The gold standard is MAC3, mercaptoacetyl triglycine. Okay. And now tell us, how will you treat renal stones? If it is less than 3 mm, etc., it will come out by itself, right? And then otherwise, yeah, that's what they're saying. You use flush therapy. So you just give them a lot of water and ask them to expel if it is small size. Then if it is a little big, then they're talking about extracorporeal shockwave lithotripsy. Extracorporeal means from outside. From outside your body, the shockwaves are sent and they try to break these stones. Okay, so it is extracorporeal shockwave therapy. This you can do. But again, there are some limitations for this. And then you can try this endoscopic procedure, which is percutaneous nephrolithotomy. Okay, this is important to know. Percutaneous nephrolithotomy. When will you do this? Because cystine stones and all are very hard, that you cannot do extracorporeal. You have to go endoscopically. And also if it is a large stone, then again you'll have to do a percutaneous nephrolithotomy. Okay. So there are a lot of terms here that you should know. So we are not going into much of detail. A separate video is there on all this. Now check this out. BPH, benign prostatic. Yes, say the right word. What is H? H is hyperplasia. Okay, don't forget. So open this benign prostatic hyperplasia. So basically old men, what will increase in size? The transitional zone or the medial lobe, which you're seeing here in yellow, that is the one that will increase in size, right? And it will squeeze the urethra. Which urethra? Prostatic urethra. So the person will have a lot of urinary symptoms. So you will have to go via this penile urethra. You have to go here and remove all this extra prostate tissue. Okay, so that only they are calling as TURP. So they're talking about some medical treatment where you will give finasteride, etc., alpha reductase inhibitor to work on the testosterone basically, and you also have alpha blockers. You can remember tamsulosin, prazosin, so that these people will urinate easily. Okay, a lot of people are given tamsulosin. You can see older men, they are given tamsulosin. Surgical treatment, you will have to remember these names. TURP, this is the gold standard, transurethral resection of the prostate. You will go via the urethra and you will remove this. What did I say? You will remove the prostate tissue. Okay. Then you have one more thing, transurethral incision of prostate. Very important for you is TURP for the exam. You should remember that you will irrigate with what? With the water or glycine. You will irrigate when you are removing these bits of prostate, and remember it can cause water intoxication. That's why you should not do the surgery more than a certain duration of time. Great people. Now let's move on to the next question. Varicose veins, guys. So again, on varicose veins we have separate video. Just let's look at. Great. So varicose veins means what, guys? So this is the next question. Look at this. So varicose veins, you will see in people who stand a lot, like security guards, teachers, etc. So they'll have this dilated, tortuous, elongated veins. Especially the superficial veins. So you can only see the superficial veins, right? So this is what is varicose veins. So these people can have this kind of appearance of these veins. There can be pain, there can be pigmentation, eczema, itching, ulcers. Okay, so these can be venous ulcers. Okay, and there is something called as this hardening lipodermatosclerosis. Okay, this you should know, and you should know the gator areas which are affected because of venous stasis. And venous ulcers are where? On the medial aspect. So if you look at the right leg, so here you can see on the medial aspect you have this great stiffness, and on the lateral aspect they are, and behind they're showing you the short stiffness. So both of these you should know. And the complication with these vein surgery and all is the nerve that goes along with this. Like long stiffness, the saphenous nerve can get affected. Short saphenous vein, when you're working on, you can affect the sural nerves. So that is what you have to pay attention to here. So if you didn't understand, it's written here. See here. See, long saphenous, which is the nerve that goes along with it, is the saphenous nerve. And short saphenous, what goes along with it? The sural nerve. So which nerve will get damaged in which surgery, you will be able to tell. Saphenous. Okay, long saphenous. Short saphenous, sural. So which is the syndrome? They are asking where the valves are absent. That is called as Klippel syndrome. You can remember, valveless. Okay. So you can see the venous ulcer here. It will be on the medial side of the leg usually. Gator area. The tests that you do are the Brody-Trendelenburg test, the Tourniquet test, the Perthes test. I think that's for DVT, right? Then you have the Pratt's test, Fagan's test, Schwartz test, Morrissey's cough impulse. All these tests you should know about. Some anatomy also you should know, guys. The septonofemoral junction. How will you mark? What's the surgical anatomy of the leg? You should know. Then you should know about the perforators. Okay. So the perforators of the lower limb, you have the hunting dog bites 3 cock. That is the Hunterian, the Dodd, the Boyd, and the Cocket. Right. So these are the perforators of the leg you should know. Okay. So the hunting dog bites 3 cocks is the mnemonic we are using. A lot of people use other mnemonics. You can use them as you want. Okay. Very, very important in the treatment is the Biscard regimen, guys, for varicose veins. You have to bandage it and elevate the leg, right? Biscard regimen is so important. They'll ask you in Viva. They will ask this Biscard regimen. So basically, you will clean it, then elevate the limb, put crepe bandage, active exercises. So you have to teach the way of walking. Heel down first, okay? Heel down first is the way of walking to prevent equinovarus, okay? So this is very important. Biscard regimen, very, very important. Guys, what did we want to tell you? There is just too much of information. Anyways, look at the varicose vein video, okay? Then there is the Trendelenburg operation where you have to remember what and all you are ligating, okay? So just remember all this. So guys, we have finished till here. Okay, now let us talk about melanoma, melanocytes. Basically this, what you should know about this melanoma, that ABCDE, asymmetric borders. This one, guys, you remember how you will describe it, ABCDE. So this one we are talking about. Asymmetry, border is irregular, color has changed, diameter is greater than 6 centimeters, it's evolving and elevating. So basically if there's anything that is changing, you should go to the doctor. That's what they're trying to say, okay? So melanoma. In this there are so many types. You have the lentigo maligna melanoma, then you have the superficial spreading melanoma, you have the acral lentiginous melanoma, then you have the nodular melanoma, right? Then you have the This is nodular, what you're seeing here. This is nodular. Then you have many varieties. Okay, okay, fine. So we'll not go too much into it. So what they're saying is ulceration is a very important thing. Then they're talking about some satellite nodules, nodes, LDH. All this they're talking about and as important ways of staging. So they're doing surgery basically, okay, for malignant melanoma. They will just do wide excision. Remember, okay, wide excision. So that is what you have to write. Most of these things will be wide excision only. Wide excision they do, and some depth is how they'll remove, so that that's what they'll excise it, okay. And some lymph node dissection and all can be done. Block dissection, etc. They're talking about block dissection. See, that word is very common here. Block dissection, block dissection, block dissection, block dissection. So all this, that's what they're telling is the treatment for this malignant melanoma. And apart from that, they're talking about radiotherapy, chemotherapy. Chemotherapy, they're talking about dacarbazine, okay, for melanoma. How's it going, people? See, there are a lot of other things that and all is covered in malignant melanoma video, okay? You look at that. Now, coming to hernia. Hernia means what and all hernias are there. Direct is there, indirect is there. Then you have inguinal, which is the area. In inguinal itself, you have direct and indirect, right? So all this you should know how to test for hernia, cough impulse. Then you will do external ring invagination, which they actually don't do. Deep ring occlusion test you can do. Then you can do the Z-Man's test, right? 3-finger. Mostly hernia is a clinical diagnosis. Okay, that's what you will write. What are the treatments for hernia? You have the herniotomy. That is just push everything, remove the sac gone, no hernia. Okay, that will usually in children. Then you have the this is what was this? Herniotomy we told. Okay, then you have the herniorrhaphy, where you have the Bessenis repair, Scholdi's repair, etc. There you will not use any mesh. Then you will just use sutures and pull it, etc. together. Then you have the hernioplasty. Hernioplasty is where you use the mesh. Okay, this type of mesh. So Lichtenstein repair and all that. So mesh you will use. Okay. So this is hernioplasty. So you have herniotomy, herniorrhaphy, hernioplasty. All this you have learnt where in hernia video. Go and watch that. Coming to pancreatitis. Pancreatitis will lead to what? Pseudocyst of pancreas. Pseudocyst of pancreas will be there what? In the lesser sac, isn't it? And basically it will have the pancreatic secretions. If somebody asks you why pancreatitis is caused, you will say alcohol, gallbladder, same standard things. Why is pancreatitis caused? Say alcohol, gallbladder, gallbladder stones. Okay, don't forget. Some signs are there, like Grey Turner sign here. You can see discoloration of the flanks. It can be there in many other, nothing to do with pancreatitis, especially singly. Okay, it can be because of other causes. Cullen sign is discoloration around the umbilicus. Acute pancreatitis, they are saying that you can give dopamine, vasopressors, blood transfusion, antibiotics, calcium, magnesium, and all you can give. So that's what they are saying for acute pancreatitis. They may also do surgery. Okay. Basically, you should understand what is the surgery you will do. If there's necrosis, you will remove it, necrosectomy. Then you will also, if there is because of gallstones, you will do gallstone treatment. Cholecystectomy. Yeah. Guys, focus here. For chronic pancreatitis, they are saying the surgical best treatment is the longitudinal pancreatico-jejunostomy. Okay. So you should know this. Longitudinal pancreatico-jejunostomy. Okay, now coming to pseudocyst of pancreas. Pseudocyst means, where did we tell you? It will be there in the lesser sac, right? Now, how will you treat this? They're aspirating the fluid here. Anyways, what are they talking about? Focus here, people. We're talking about the surgery for pseudocyst. Okay, surgery for pseudocyst. There is some, cystogastrostomy. So, they are making a connection between the stomach and the cyst, and they're saying that for some reason, the food does not enter the cyst cavity, which is very good for us. Okay, so it will help the drainage. Okay, that is one thing. Then a lot of other surgeries. What are the steps for cystogastrostomy? Okay, then they are doing distal pancreatectomy. If it is the tail of the pancreas, just remove the tail and the cyst. Then they are talking about cystojejunostomy. Cystojejunostomy, guys, focus here. Some roll N Y loop, Y loop. Okay, Y loop. Okay. Relax, people. We are looking at the surgery important topics. Hope you are revising and you will be able to do well in your examination. Now let's move to the second half of it. What do you say, people? Great, people. Now we are moving on to what? Anal fistula. Top priority questions. Anal fistula, what you should know? What exactly fistula is, right? Connection, abnormal connection between two epithelium lined tracts and with granulation tissue, right? And here you have so many types. We have covered this in the anal fistula video. Park's classification, it is called as, you have the intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. Okay, so these are the four things that we have tried to explain here. And here you're seeing 5 lines. The one is the superficial one. Okay, other than that, what are there? Intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. Okay. Achalacia cardia, that is your lower esophageal sphincter is so tight, right? It is not allowing the food at all inside. So here you will have that bird beak kind of appearance, etc. Remember here the surgery you will do is myotomy, right? The cardiomyotomy. The surgery name is called as Heller's myotomy. Okay, so because it's not opening at all, the lower esophageal sphincter doesn't relax at all. So they are doing this myotomy. Okay, Heller cardiomyotomy. Just a few more to go. Yeah. Okay, then stomach cancer, what you should know, it's silent cancer because it will appear elsewhere and then you don't even know that actually the secondaries can appear before the primary. Okay, that's what I'm trying to say. Silent it is. Here they are showing you all the secondaries that can be there. Liver secondaries can be there. Then Krukenberg's tumor, all these can be appearing. In this only you have the Sister Mary Joseph nodules, right? All this you should know. So basically, what is the treatment? They're talking about carcinoma of antrum means what you'll do, distal part means what you'll do, proximal part means what you'll do. Then what is palliative surgery, all that they're talking about. So here they are talking about a distal. Distal means what they are doing, they will directly, that distal part they can remove, right? And they can connect the proximal and the intestine. See this one only, they are removing the distal part and they are connecting the proximal to the intestine. So this is some radical subtotal gastrectomy with Billroth 2 anastomosis. Okay. Then they are talking about what happens if proximal is affected. If proximal is affected, what will you do? They are talking about esophago-gastrectomy or radical total gastrectomy. Okay, this is radical total gastrectomy they are saying. Again, that Y, Rowan Y stomy. Then palliative means subtotal only if just to help the person live for a long time without pain. Palliative. Look at one photo for palliative. Okay. So here they are telling you palliative. Anterior GJ. Is it becoming too much, people? Okay, just let's quickly cover. Okay, appendicitis. See, appendicitis only if it is acute within the first few hours, then only they will operate. Okay, if it is beyond, then it will form an appendicular mass. Okay, so that you should know, appendicular mass they won't treat because it will be trying to bind it, confine the infection. So that you should pay attention to. In appendicitis, what are the important points? Cause can be fecalith, okay, remember calculi, etc., which is blocking, and that will be obstructive cause. Non-obstructive will be what? Some infection, okay. Then coming to clinical features, here there are some names, okay. First it will come to umbilicus, then it is coming towards this right iliac fossa. This is called a shifting pain, migratory pain, okay. It's the most reliable symptom they are saying. Then you have the, what else you need? Murphy triad, pain, then vomiting, then fever. So they're having some Murphy triad here. So you can say anorexia first, then you have the shifting pain, okay, shifting pain, and then vomiting, and then fever, right? That's what is this Murphy triad, okay. Then what are the signs? You have the Dunphy sign, cough, tenderness. Dunphy sign, you should know what McBurney point is. Then you have rebound tenderness, which is called as Bloomberg sign. Remember, that means there's peritonitis, right? Inflammation of the parietal peritoneum, Bloomberg sign, rebound tenderness, all these are very important words that you will write in the examination. Then you have the Rovsing sign, guys. When you palpate from the left side, you can feel pain on the right side. Okay, then hyperesthesia in the Sharon triangle. So where is the Sharon triangle? Because of the nerves, okay, that are there here. So this is Sharon triangle. So all these are very important signs. Then you have the psoas test, Cope-Psoas test, Cope's obturator test. So many things are there. Pay attention, people. Now we are looking at the treatment. There is very, very important one terminology here called as the Ochsner-Sharon regimen. Okay, so this is actually talking about how the person will be nil per oral. They will not be eating food via mouth, and they will be on antibiotics. Okay, very important to know this Ochsner-Sharon regimen. Where does it come? In appendicitis. Good, people, you finished appendicitis. Now coming to varicocele. Varicocele is something to do with the testis. Very good. So we have our own video, guys. You can look at this. So the testis, you can see the veins, what are those pempiniform plexus, is it? So all these are affected. So basically you can see here what are the causes. Why is it more on left side? You should understand, because the drainage from the testis, right, into the renal vein IVC is at 90 degree or something. That is why you should know that. Clinical features, then how will you grade it? What are the complications? Treatment, Palomo's operation. So here you can see the pempiniform plexus and then testicular vein and how it is draining it to the left renal vein, and then the IVC. All this you should know because of the anatomy here. That is why left side it's more. See, if it is visible, then it is large, grade 3. Okay. Treatment, again surgery only you are reading, no? So excision of the pempiniform plexus. Then you have the Palomo's operation, retroperitoneal approach we told you. Okay. Details of all this, it's better you look at varicocele video. Basal cell carcinoma, very important, guys. Rolled margins, they'll ask this even in medicine, in surgery, all the topics they will ask this. Again, wide excision is the option here. Okay, the surgery is wide excision. So it's also called as rodent ulcer. It is a malignant condition of your skin. It will come above this line which is connecting your angle of what is this, mouth to the ear lobe, looks like. Right, so it is rodent ulcer, we told you, right? It will give a burrowed kind of a like it has burrowed, a rodent has burrowed kind of a thing. Then what will you see here? You can remember nodulo-ulcerative, it's slow growing, and this is not completely it is malignant, but it is locally invasive only. Here you can see the stratum basal. See, like all the cells have come in, so a lot of stratum basal here. So that's why basal cell carcinoma. Dermoid cyst is actually, you can write for ovary, okay, teratoma, very important in that. What and all will be the hair, teeth, basically all three germ layer stuff will be there in it. So again, excision only, dermoid cyst. Action actual name is benign cystic teratoma. Dermoid cyst is misnomer. Okay, it's nothing to do with skin. It is not only skin component. Every component will be there in it. Okay, germ cell tumor it is. So here they are showing you all this teeth, the hair, everything is there here. Okay. What is the complication? Means it will twist on itself. The ovary will twist on itself. That is only the complication, torsion. Okay. So surgery, they are saying ovarian cystectomy, ovariotomy, total hysterectomy if needed. Now let's go to Crohn. C-R-O-H-N, Crohn's and ulcerative colitis. So basically you should know the difference. Crohn's will be skip lesions will be there. Ulcerative colitis, no skip lesions. Actually ulcerative is kind of ascending. So we have separate video on this. Remember Crohn's, as it is having skip lesions, it's very difficult to operate on it. Okay. Ulcerative, however, it is continuous, so you can operate on it. Okay. And ulcerative is superficial. And basically look at the treatment for both of this. You will give glucocorticoids and azathioprine, methotrexate, standard treatment you will give. But for ulcerative colitis, what you can do is, as it is continuous, in ulcerative colitis you can operate, and you can remember that you can give here 5-ASA, that is salicylic acid, some derivative. What is that? Amino salicylic acid. Okay, the 5-ASA works only for ulcerative colitis. It is also called as mesalamine. Okay, it is anti-inflammatory. So surgery will help, and 5-ASA will help where? In ulcerative colitis. Very good, people. So now you have looked at almost the last point that we wanted to cover here. Then intestinal obstruction. Intestinal obstruction, so many varieties of intestinal obstruction are there. See, because of something in the lumen, or because of something in the wall, or something outside the wall also can cause an obstruction. There are other ways of classifying, like whether it is a dynamic, that is a mechanical obstruction, or a adynamic, that is a paralytic or a neurogenic obstruction. In this you should know Ogilvie syndrome. Then there are something called as Hirschsprung disease. All this terminologies will come in intestinal obstruction. Hirschsprung disease, remember, Ogilvie, then you have paralytic ileus, all that comes here. Because adynamic means it is not mechanical, it is something to do with the nerve, etc. Pay attention here, guys. Whenever you do surgery, after that you have to check whether the person is emptying the bowel, bladder, etc. If they are not emptying bowel, it can be because of paralytic ileus. Okay, so after an operation you should be careful about all this. Okay, so because of these nerves, suddenly they get irritated and they'll say, no, Maze, we are not going to pass the bowel anymore. So you have to tell them to you have to treat it. Okay, so basically how will you treat it? A drip and suction, they are talking about drip, suction, drip, suction, drip, suction. And if it is because of hypokalemia that it is paralyzed, then give potassium. Yay, people, you completed the top right. These questions don't give you a clue as to which organ it is from. So better to know these terms, okay? So what is Burgess disease, guys? Something to cause your peripheral vascular disease, thromboangiitis obliterans. Charcot triad you have seen in gallbladder, cholangitis, right? Then Marjolin ulcer, something to do with burns, etc., the scar. Then Courvoisier's law, gallbladder. If you can feel a gallbladder and there is jaundice in this person, most probable cause is not gallstones. Okay. A Goodsall's rule you have seen where in fistula. Fistula, basically they're telling you, if it is posterior, it will not be going directly. It will go here and there. Okay, that is what they are saying in Goodsall rule. Then carbuncle means what? In diabetes, those multiple, pus-filled cluster of boils. Basically in diabetic people, this will be there. Okay, so this they have treated and they have removed all the pus. What is epulis? Remember, okay, painless swelling upon the gum. Okay, remember epulis. Please write epulis means gums. Okay, you remember it as gums. Okay, gums means where will be? In the mouth. Yeah. Mailed hernia means what? The W. In Google, if you search mailed hernia, maidal hernia, you will get tower video only. See this W, and you can see the strangulated part is there inside. Okay, WW. Okay, remember. Then phimosis, something to do with the penis, isn't it? You remember that very well. So foreskin is so tight, you cannot retract it. So basically here, this is the only actual indication for circumcision. Then Shataki's ring. What is this like? Sounds like Pataki ring. See, there's a stricture here, esophageal stricture, Shataki's ring. Okay, if you can remember this is something to do with esophagus. This is something, just remember here, next to each of this you write off one word. Okay. Sister Joseph nodules, just now you saw. Where did you see? Some umbilicus. Yes, stomach carcinoma. Very good. Lad band also is GI. Basically this below the stomach. You can see here duodenum, lad band. So basically what is this causing? Intestinal obstruction, lad band. I think this Monders we missed. Monders, let's do it. Monders, basically thrombophlebitis, superficial veins of breast, anterior chest wall. Okay. Then coming down here, Mercedes Benz sign, we already told you, gallstones, erysipelas. Infection of the upper layers of the skin is superficial, is caused by streptococcal bacteria. Millian's ear positive sign. So something to do with the skin. This one. Now let's come to cafe au lait spots. This you will see in what? Neurofibromatosis, neurocutaneous disorder. Focus here, people. These are the neurocutaneous marker. Cafe au lait spots, neurofibromatosis. Last one, guys. Very good, very good. Oshner Sharon regimen, appendicitis, nilper oral antibiotics. So these are the specific terms you should know. Now let's move on, guys, to the next slide here. What exactly, how to pass